This is the Transition Series Topics for the EMT. Topic 7, Regulation of Ventilation, Ventilation Perfusion Ratios, and the Transport of Gases. Our objectives are to review how the body regulates normal ventilation, explain how feedback systems in the body can influence ventilation, discuss the VQ ratio and how it influences the body, and identify the role of red blood cells and hemoglobin in oxygen transport. Understanding how the body ventilates and oxygenates is integral to proper care. This chapter will look at several components within an organism with a focus on how ventilations are controlled and how oxygen is transported. Regulation of ventilation, fortunately, is not normally managed on a voluntary basis. We don't think about our breathing, we just breathe. Feedback to the brain on the effectiveness of our breathing is provided by chemoreceptors and lung receptors. Chemoreceptors are specialized receptors that monitor the number of hydrogen ions, that is to say the acidity or pH of the blood, and the amount of carbon dioxide and oxygen in the arterial blood. There are two types of chemoreceptors, central and peripheral. Lung receptors are structures within the pulmonary tissue that cause a change in the quality of ventilations when stimulated. These receptors include monitors for irritating gases, changes in capillary bed pressure, and how much stretch is occurring in the lungs during ventilation. Chemoreceptors are located in, as we said, come in two varieties, central and peripheral. Central chemoreceptors are located in the medulla oblongata at the base of the brain. They monitor carbon dioxide in arterial blood and the pH or acidity of the cerebrospinal fluid. The pH of cerebrospinal fluid is directly related to the carbon dioxide levels in arterial blood. An increase in the amount of carbon dioxide in the blood will increase the amount of lactic acid in the blood. A decrease in the amount of CO2 in the blood will decrease the amount of acid in the blood. As the acidity of the body rises, the central chemoreceptors detect the change and stimulate the respiratory centers to increase the rate and depth of breathing. As levels of acidity drop, the central chemoreceptors will detect the change and cause a slowing of the rate and depth, which causes the body to retain more CO2 to return the pH to normal. This is an exquisitely delicate balancing act. Peripheral chemoreceptors are located in the aortic arch and the carotid bodies. These chemoreceptors are also sensitive to CO2 and pH, but arterial oxygen levels are their strongest stimulus. So if our arterial oxygen levels decrease, these receptors will trigger the respiratory center to increase the rate and depth of respiration. A significant decrease in arterial oxygen content, then, will result in an increase in the rate and depth of ventilation intended to increase the arterial oxygen content. There are also lung receptors. They are irritant receptors, stretch receptors, and J receptors. The irritant receptors are found in the airways and are sensitive to gases, aerosols, and particles which irritate the lungs. When irritated, the lungs respond with coughing, bronchoconstriction, and an increase in the rate of ventilation. The stretch receptors are located within the smooth muscle of the airways. They're responsible for giving feedback on the stretch of the lungs. They prevent overventilation when stimulated by high tidal volumes. by sending impulses to decrease the rate and volume of ventilation. J receptors are located in the capillaries surrounding the alveoli and are sensitive to increases in pressure within the capillary. When activated, these receptors send impulses intended to slow and make respirations more shallow. This drawing shows us a cross-section of the brain showing the medulla oblongata, and within it the pneumotaxic centers, the central chemoreceptors, the apneustic center, the ventral respiratory group, the dorsal respiratory group, and the vagus nerve. In the lungs these are the central chemoreceptors. The peripheral chemoreceptors include the carotid bodies here in the carotid artery, the aortic bodies in the aortic arch, and the stretch, irritant, and J receptors within the tissue of the lung. Regulation of ventilation is broken into two major drives: the hypercapnic drive, which responds to the levels of carbon dioxide in arterial blood, and the hypoxic drive, which is triggered when oxygen levels become too low. A person's ventilation is normally controlled by the strong stimulus provided by the level of carbon dioxide in arterial blood. This is referred to as the hypercapnic drive or hypercarbic drive. Unfortunately, patients with chronic obstructive pulmonary disease, such as emphysema or chronic bronchitis, have a tendency to retain much more carbon dioxide in their arterial blood due to the poor gas exchange that they experience. Because CO2 is chronically elevated, the central chemoreceptors become desensitized to the fluctuations that would normally stimulate ventilation. Since they become desensitized, the peripheral chemoreceptors become the primary stimulus to control ventilation. Thus, hypoxia, or low oxygen levels, rather than CO2, becomes the primary stimulus for breathing. This is referred to as the hypoxic drive. The dorsal respiratory group, which we saw on the illustration, is responsible for determining the basic rhythm of inspiration. It consists of the dorsal respiratory group, the ventral respiratory group, the apneustic center, and the pneumotaxic center. The ventral respiratory group has both inspiratory and expiratory neurons. However, the VRG is basically inactive during normal quiet breathing. It becomes active when accessory muscles are needed to assist in respiration. The apneustic center provides stimulation to the dorsal respiratory group and the ventral respiratory group to intensify inhalation as necessary. And the pneumotaxic center sends inhibitory impulses to the apneustic center when the lungs become overinflated. The ventilation perfusion ratio, or VQ ratio, describes the relationship between the amount of ventilation and the amount of perfusion in the lung. Ideally, the amount of air entering the lung and the perfusion of the tissue beds would be a 1-to-1 ratio, but it is not. There are many variants coming to bear on the VQ ratio. For example, the effect of gravity on blood flow, the structure of the lungs, if shunting is occurring. Many etiologies of respiratory distress are expressed in terms of the ventilation or perfusion deficit. Pressure imbalances may cause the pressure in the alveoli to exceed the hydrostatic pressure in the alveolar bed. That is to say, that it becomes more difficult for oxygen to move into the alveoli because of increased pressure of the blood. An example of this would be shock due to hypovolemia. Perfusion of the pulmonary capillaries is affected by pressure within the alveoli and pressure within the capillaries. Perfusion, or passing of blood through the tissue bed, occurs here in the capillaries of the alveoli, which lie only two membranes or two layers of cells away from open air in the alveoli. Elastin fibers affect the stretchability of the air sacs, which is diminished in people with emphysema and chronic bronchitis. A disturbance on the ventilation side of the VQ ratio can lead to hypoxia. If a condition or injury causes less oxygenated air to be available in the alveoli, the end result would be less oxygen saturating the blood and less oxygen delivered to the cells, creating hypoxemia and cellular hypoxia. Ventilatory disturbances are conditions then that result in wasted ventilation, inadequate ventilation of the alveoli, and the correction is to provide sufficient ventilation to enhance the alveoli or alveolar ventilation. Perfusion disturbances may also lead to severe cellular hypoxia. For example, hypovolemic conditions may cause insufficient blood volume to be circulating and therefore decrease perfusion. The correction is to enhance perfusion by providing additional fluids, by placing the patient supine, and otherwise helping correct the loss of vascular volume. Most oxygen is transported in the blood attached to the hemoglobin molecules on red blood cells. Around 98% of the blood is transported attached to a hemoglobin molecule, and less than 3% is dissolved in the plasma. Clearly, if there is insufficient hemoglobin in the blood, or insufficient red blood cells, insufficient oxygen would be present to keep a person alive. Loss of hemoglobin through bleeding is usually the cause of severe cellular hypoxia. Carbon dioxide is transported in three ways. About 7% is dissolved in plasma, 23% is actually attached to hemoglobin, and 70% is bound in the form of bicarbonate. When CO2 leaves the cells and crosses into the capillaries, a small amount dissolves in the plasma, a larger amount attaches to hemoglobin, and most of the CO2 combines with water to form H2CO3, or bicarbonate. When the bicarbonate reaches the lungs, the carbon dioxide will dissociate from the water, and the carbon dioxide will diffuse into the alveoli to be exhaled. In summary, oxygen transport mostly happens on the red blood cells. CO2 transport mostly happens within the plasma as bicarbonate. Alveolar capillary gas exchange occurs in the lungs and is a matter of simple diffusion. Venous blood is low in oxygen and high in carbon dioxide. Alveolar blood is high in oxygen and low in carbon dioxide. When red blood cells pass by the alveoli, the gases diffuse across the membranes to achieve equivalency, because in concentrations, molecules tend to diffuse to achieve a balance. So in the pulmonary beds, blood which has more carbon dioxide than oxygen will tend to give up its carbon dioxide, which will want to equalize with the air in the alveoli, and the higher concentration of oxygen in the alveoli will tend to diffuse oxygen into the bloodstream to attach to the red blood cells. In the capillary beds, in the cellular beds, there's more carbon dioxide than in the blood, so carbon dioxide will tend to diffuse into the blood, and oxygen will diffuse from the blood to the lower level in the cellular beds. This constant exchange of oxygen and carbon dioxide in the lungs is a fundamental condition of life. Without it, we die. In summary, consistent with the other chapters in this section, understanding the cellular level of function will assist the EMT not only in interpreting the patient's problem, but also managing it more efficiently. If our cells are not provided sufficient oxygen, and if adequate carbon dioxide is not removed, cells will die, and eventually the patient will die.